Here I will be presenting a new technology that is wide field, ultra wide field angiography and imaging system. This is a multimodal imaging system. This is the advantage. We get not true colored images, but the advantages over other system is that here they use 3 lasers, unlike Daytona or any other systems available, and therefore it's quite closer to true natural images. So how has it helped me in my practice? Let us understand through this. I don't see the screen moving over here. So, well, this Nitin has already briefed you, so why we did it. This is what the conventional and all the things we see, wide field and ultra wide field. I would just come directly to my part. The system offers us the advantage as well of a wide field OCT. The standard OCTs, we get a section of 9 to 12 millimeter, while in a wide field here you get a 16 millimeter, and so you can pick up extramacular pathologies like choroidal melanoma or a RD versus retinoschisis. I would be subsequently elaborating the cases I will be showing. So like directly we will move to the certain clinical situations, like what happens, what are the advantages which I get when I am doing a case of a diabetic retinopathy. So you can see actual cases of non-perfusion, quantify the non-perfusion, which we really talk about. We should have 10 diopter, 15 diopters, then we should treat the laser in a case of a BRVO or something like that. You can pick up a peripheral NV, and you can talk about doing a guided or a targeted PRP, which we talk about being less damaging to the laser. So now look, this is the one of the patient who had undergone an angiogram elsewhere. This is a case of a PDR. This is a case when we did at a wide field angiography, and you can see for yourself the difference what you are seeing. See the extent of the disease. This was a lasered patient. You can see a poorly done PRP and needing much more. We did an angiogram, and now it is speaking for itself. See the amount of dropouts. I don't need to talk more. We all are a retina specialist, and this is ultra wide field. You can see. So actually where you need to treat, you can understand. So I don't need to tell. Now looking at RVOs, this is what we can get in a standard fundus and a angio which area which we see. Now look at a ultra wide field. Look at the extent of the disease where you can actually see. Can I have a pointer over here? Yeah. This is the whole thing. While here previous you could see hardly this. So you would treat this area. So now the concept of even in a case of vascular retinopathy to go beyond equator to complete a sectorial or a pan-retinal photocoagulation, you are justified in doing. Otherwise a standard teaching would be to treat up to equator, moving from vascular arcade up to the equator. But this cases will convince you why you need to go beyond the equator. Now this is what the ultra-wide field is. You see the extent of the damage. Now coming to case number 1. He's a pulmonologist from our town who had a BRVO. He was with us for a long follow-up even before I got a ultra-wide field. He had macular edema secondary to it. This is what I did, an angiogram for him, and we treated him with anti-VEGFs. And every 3rd, 4th week he would need further injections, and we did not understand how to proceed. Then by that time we had this machine, and at that point we did an angiogram, and you can see the extent of disease over here. You can see the dropout even in the periphery. So we decided that what we should do is we'll target these areas as well to treat beyond, and this is much beyond the equator, and we did treat it with a targeted peripheral laser only, not the sectorial laser which was earlier done, and we could get a resolution of the edema. This is how what we learned. We learned that yes, and then we went to the literature which says that vascular abnormalities in diabetic retinopathies are quite beyond the equator and needs treatment, and therefore UWF will help you in picking up these areas. This is what literature always told us, but we never bothered about it. Now case number 2, another case which was diagnosed at cystoid macular edema and was advised Ozudrex. This person comes to me, you see ultra wide field, I knew it is a retinoschisis, and a ultra wide field, I get a 18 millimeter, 16 millimeter OCT scan, and my diagnosis was clear. But yes, see what happens is, even in a case of a retinoschisis, had I done angio, I would have got this. But when I did an wide field, I could see peripheral vascular looping as well. So a vascular response in a case of a retinoschisis, which we learnt in literature, is what we saw over here in a case of a retinoschisis. Now this is what exactly I am trying to show. The vascular response in a case of a retinoschisis, which might need treatment, be it in the form of lasers or you want to treat it with anti-VEGFs, is a matter of choice. So this is how we learn from it. Now case number 3. This was a case which was diagnosed at epiretinal membrane and was posted for surgery. She was a young girl. It was not convincing for me. So this was the picture. Yeah, it was almost a retinal disc drag as well as this. We thought something is fishy over here, and when we did, this is post surgery, somehow I missed my angiogram over here. It was a case of FEVR, in fact. So we had to do a vitreous surgery. We had to treat even the periphery. This is a Ozodrex implant as well. So a case of epiretinal membrane. Yeah. FEVR. So there was a vascular tissue which I could see through it. Somehow I misplaced this particular angiogram. We are not able to place. And so we had to target, when we went for vitreous surgery, we had to treat this part also of the disease. That is what we learned. Now coming to another case, hypercholesteremia. You could see this multiple dot hemorrhages on a standard fundus photograph. And what do you see on an angiogram? A terrific shutdown. All across the peripheral shutdown. While the clinical photograph, if I go back, this is all I could see. The whole disease was in a periphery. Now look at it, how a wide field angiogram can help you in making your diagnosis easier. So I don't need to say what I need to treat you. Another case, 26 years female. Now this is the case of a treated case of choroiditis. She complained of blurred vision. Well, I could see the scars. We did an angiogram and it was like this. It was showing the scar staining. Look at the color photo. We did an ultra wide field angiography. Yes, scars were only scar staining, but if you see, the dropouts have started in the periphery. So a choroiditis associated with a ischemia. Now your line of treatment is totally different. You don't need to just treat it. You need to treat it with lasers if you think, or treat it with an anti-VEGF, whatever is your choice. Case number 6. She was posted for vitrectomy for combined vascular retinopathy. Well, this is the picture in that eye, and other eye was done elsewhere. We thought on a wide field angiogram there is something abnormal. I was not very convinced. So we did an angiogram for the other eye, and this is a publication cover page of ophthalmology. This is Takayasu's. So we needed to treat the better eye first, which was asymptomatic, and ultra wide field changed my treatment totally. Case number 7. Now a young girl who came to me had a thiazical eye in right eye, and she came to us for her father was operated for glomus jugulare. Grandfather had some history of brain tumor. This was the picture. Can you see certain small vascular? So if in these machines you have the imaging system where you can get a camera and see it in a high magnification. We advised FFA. Can you see some vascular tumors there? Yes, which was never possible to us. This is angiomas, von Hippel-Lindau. We treated her. This is now a post-operative follow-up. We went to father. We asked him to get a wide field angiogram and see that case. Multiple angiomas in the periphery. We asked her brother to come to us. Again, it was asymptomatic, and see the large angiomas which you could pick up. This is what it helps you in all this. So this is brother asymptomatic post laser now. Now we are going to do yearly wide field angiogram for this patient. And what we learned, yes, this is how we did then a genetic part study and all. And this has to be yearly done only with wide field angiography. We would have missed on a routine angiogram. Case number 8, pseudophakia. This is the picture at presentation. She is a 80 years female. This is a peripheral PCV with an encroaching fluid onto the thing. We treated with brolucizumab, and look at the advantages of a large field OCT. Even through the peripheral part, we can have a OCT, the fluid percolating into this. This is the advantage of a wide field OCT image. And we did an angio, and this is how we can follow up. You can see the tumor, coming down in height for yourself. This is how it happens. Now coming to case number 10. This is a patient who complained of flare in antechamber, decreased vision. You can see multiple fluid pockets across. We did an angiogram. It was a case of a FAF, VKH, which was then subsequently treated, and angiogram showing necessary information. I would just, for want of time, now run through it. This is an ICG angiogram, which is also possible with this system, unlike other, being a multimodal imaging. Case number 11. This is the picture which was diagnosed as a CRO elsewhere. So this is the picture on an ultra wide field. It is self-explanatory. This is a case of a RP with a macular edema. Case number 12. Now she is a premature baby, referred to us for anything. Now look at this. This is the routine standard photograph which was taken by one of my colleagues. And when we did an ultra wide photograph, self-explanatory, retinoblastoma, multiple tumors with seedlings all across into the vitreous. This is so convincing to the patient that you don't need to speak to them further. Case number 13, blunt trauma. This is the picture again taken elsewhere, normal edema, and this is what we see, an horseshoe tear. Another case. This is another case which we see. You can see a subclinical RD over here with a HST over here. This is so convincing to the patient. Subclinical RD, it was in fact posted for an anti-VEGF elsewhere based on an OCT, previous OCT. Case number 15. Now this is a case of a subclinical RD. You could show the patient what it means to have a lattice degeneration. We could treat the laser, do the laser first for the better eye and then treat the other eye. This is how it helps you in convincing the patient. Another case, I will just run through this. These are routine cases now, how it helps. This is another case of, you can see multiple dot hemorrhages over here. This was decompression retinopathy. So convincing to a patient. Another case, if you look at it, leukemic retinopathy. The pictures itself speaks for us. Now we have an additional feature with this machine, what is called a retro mode. So now let's move to the role of retro mode in imaging in macular pathologies. So what is retro mode to tell you? See, we all know now, are convinced that the hot set of activity in any retinal disease is RP. Most of the diseases now are implicated to the RP because of the various things which are happening at RP level. Now these are the things which are happening. Now let us move. So what is retro mode? What we learned is something like a retro illumination from slit lamp. So when you get on a retro illumination on a slit lamp, you can see structures ahead better in a different perspective. So this is what it happens in this particular thing, where they use this retro mode and how it helps us. Now this is the normal retina color photo. This is the OCT. This is FAF. Okay. And in a retro mode, in a normal retina, you see it normally like this. This is the normal configuration which you see on a retro mode. Now let us see how it sees in a diseases which affect retina. In a macula, this is a case of a typical retinitis pigmentosa. This is the color photo. This is the FAF of that particular patient. The disc is black, correct? Now look at this. You will see that the multiple bully like RP will be seen here. It will become more pronounced in the consecutive cases which I show you. In a retinal retinitis pigmentosa, RP is not the seat of activity or the disease, and therefore here the RP is not affected much. Okay, now coming to paravenous pigmentary degeneration, you can see wherever this RP is gone, even without doing an ICG, you can see the choroidal blood vessels very well delineated as if it is a ICG picture. This is how it helps us. Now coming to the cone dystrophy. This is the color photo. Look at the FAF. Again, it is not diagnostic. In a RP here, you can see bullies like. It looks like a small bully like thing. You have to get trained to see that. Once you understand what I am trying to tell you, when I show you, you see these small bubble like things. Those are the diseased RP. So if the RP becomes diseased, whenever there is an accumulation into the retinal pigment epithelium, any disease which causes accumulation into the retinal pigment epithelium, our retina becomes such bully like things, bubble like things. It starts looking like this. Now coming to RP disease, this is a case of a Stargardt disease, classic angio, FAF. Again you see in a Stargardt, these are multiple bully like RP. And in all this is more classic, you can see. So the extent of involvement, if you look at a FAF, is quite less of a RP, while in this particular retro mode, you see the whole diseased RP is quite extensive. So it tells you the extent of the disease in a more better way. Now coming to pattern dystrophy, this is color fundus photograph and this is the FAF. Here, if you see, the RP is affected in a lesser way. Still, you can see these are bully-like things over here. So this is how it helps you in a best disease. Again, some things which we will run through. I will come directly to AMD now. This is one of the most important way how to follow, because this affects predominantly RP. Now this is a AMD. You see minimum drusen over here, here. OCT is not contributory. FAF again is not contributory. Now look at the disease in this. You can see multiple bullies all across. So look at the extent of the disease, where you can see on a color fundus photograph, FAF is not contributory, while you can see all the bullies, means the extent is quite much more. So we are doing a study where we are able to count the number of RP cells with certain strategies. We will be coming out with a paper in a short while. It is it is sent for publication. We will explain you. Now look at intermediate dry AMD. Again you see few drusens over here. OCT is not contributory. Now look at FAF. Again it is not contributory. The only way to look at RP as on date was a FAF was the best way to look at it. Now look at F. You can see the whole RP over here. Multiple drusen bubble-like pictures. See, this is the thing what we are trying to see, and we are trying to understand what the information it is giving and how it will help us in. So the studies are ongoing over here. Now look at intermediate dry AMD. You see multiple drusens. OCT is not contributory. FAF again few hypo and hyper spots are there, but you see the whole RP is affected all across. So it tells you the extent, and the not only that delineation is much more, the spread is more, but the number of cells are more affected here, which we can pick up. Now look at soft drusens, how they look. Again you can see some on things which you can see hyper autofluorescence, and here you see the whole RP is bunched up. Can you visualize and understand that? That is the beauty of this system. Now look at cuticular drusens. Here drusen, now look at it, the extent of involvement. This is quite a significant one. Now that they are trying to develop the counters by which they can actually calculate the number of RP cells which are involved. And this will help us in better prognosticating. Now this is a young girl, doctor by profession, who came to us with this fundus picture. We saw drusen, we said, okay, you have some drusen, we will be watching you. So this was a dominant drusen, FAF was not contributory, and you see the extent of RP involvement. It is even on the nasal side of the disc. So we could prognosticate to that young girl who is 32 years doctor, that your RP is going to give us some trouble in future. Now coming to infective pathologies, wherever there is a scarring and the loss of RP, the choroidal vessels will stand out as if you have done an ICG. So this is a good way of looking. Wherever there is a RP loss, a choroidal vessels, even without putting an ICG dye, can be seen better, and you can understand the way choroidal involvement. Now case of retinoschisis again, you can see the wide field OCT, how it helps you. You don't need further investigations to understand this. CSCR, again we knew this is a disease of RP again, but we on an FAF, when we do, we can at the most see 1 or 2 points. Look at the retro mode. You can see multiple RP bullies over here, which says that the disease is more extensive. It is not necessarily a pinpoint look. The RP is diseased. Now we have started believing clinically as well. Previously, histopathological studies told us that RP was involved. Now another case over here. This is a case of a VKH. You see the bully RPs which are bigger in size. They are more swollen. So in a case of a VKH, the whole disease process again is at a RP level which is involved, and you can see bigger bullies over here. Another posterior VKH case which you can see on an OCT and an again you see all the RPs. Here you see the disease only localized, but you see the RPs all involved even beyond the arcades. So this is what it offers us. So this is the advantage of this particular new system is that it is true near normal color image, because it uses 3 lasers. It gives you a SLO based images which are near natural colors. It gives you all the facilities plus an additional advantage of retro mode. The clinical implications, what we could understand, and from the literature which is very scarcely available, tells us that it gives you the involvement of RP in a better way. And here we could document that the RP actual, not only the extent, but the actual number of RP cells can be more. That is what we are learning in various retinal disorders. Thank you. And besides that, many people ask me about the questions about what would be the cost of it. This is the cost which you pay. In last 18-20 months, these are the three cover pages of ophthalmology for us. This is eye. We have 2 eye cover pages, and these are our publications. Thank you.